All right. Well, thank you all for your patience for that little technical difficulty. Joe, thanks for that kind introduction. And to all of you that are there listening, I'm really humbled to have this opportunity to share with you what we do here at the Journal. And a lot of what I'm going to talk about echoes on the heels of what Professor Shah talked about. Me personally, I'm a heart failure specialist. I take care of individuals with end stage heart failure, those that need transplants, those that might need left ventricular assist devices. And then my area of investigational interest, I'm a clinical epidemiologist and I'm interested in heart failure epidemiology. And right now, specifically as it relates to cardiac amyloidosis and trying to uncover early phenotypes of individuals with that disease. So I'm not going to belabor these points, but Swati made a lot of really excellent key comments, and I shamelessly poached this slide from her because it is incredibly important that these are a lot of the things that we focus on when we're looking at a heart failure paper. They're virtually identical. So in the interest of time, I'm going to move forward and I'm going to discuss two papers that I really think encompass a lot of these standards or the quality that we're looking at. So much in the same way of the impact and validity and so forth, that Svati was displaying, I'm going to go through these papers. The first of which is the MPAG heart failure clinical trial. So this is a single center clinical trial of patients that were hospitalized in Germany, and they were randomly assigned to empagliflozin versus placebo on top of high dose IV loop diuretics. So as you can see, the results were quite remarkable. I'm showing you two figures here on the screen where there was a greater loss in body weight, which indicates that these patients were where treatment was far more effective. And then if we look at the panel on the right, we can see that this was really not at the expense of worsening kidney function as measured by GFR. So then when we talk about the impact of this paper, well, this is one of the only randomized controlled clinical trials that demonstrates the superiority of one treatment strategy versus another in patients hospitalized for decompensated heart failure. In fact, the heart failure literature is riddled with graveyards of clinical trials and novel treatments that have really been no better than placebo. So why else is this impactful? Because it certainly does shift the needle. And then the next questions that come along are, is this scalable? Is this, how do we implement this in our own practice? Should this motivate a larger study, right? So clearly this is paradigm changing when we're thinking about how to manage patients with decompensated heart failure. And I think it goes without say, this work is largely immediately adaptable to clinical care. Now, when we focus on validity, this is so crucial for any of our papers, just as Swati highlighted, but this is a randomized controlled trial. This was placebo-controlled. The investigators of this work had adequate power calculations. They were accurately measured and adjudicated endpoints. They dictated exactly at a dedicated study team that measured the urine output, and they measured a number of other biomarkers, which I'm not showing here, which were all secondary endpoints that indicated benefit in those that received empagliflozin for decompensated heart failure. As I mentioned, there was careful follow-up, and then their statistical analyses were pristine. So this really demonstrates a paper with very high impact and rock solid validity. So now I'm going to shift gears to more of an epi-based paper. This is a cohort study. So much of the research I do, probably much of the research that most people do, isn't large-scale randomized controlled trials. We do a number of cohort studies. And so this is a cohort study that really came at a crucial time within the understanding of how we manage transthyretin amyloidosis. So these data come to us from the National Amyloid Center in the United Kingdom, and they really seek to show the natural history of patients with ATTR amyloidosis. Now, what sets this cohort study apart from other maybe single center studies or other cohort studies is that the UK National Amyloid Center sees the national caseload of amyloidosis in the UK. So it is far more generalizable. And everybody that follows with their center has protocolized follow-up. So in other words, we have patients that are being followed with the disease that are getting different assessments at regularly scheduled intervals. So this creates a really nice framework where we can follow the natural history of this disease. So what was the impact of this paper? And so I can tell you that they assess their patients quite comprehensively. They follow everybody for mortal and non-mortal outcomes. They get biomarkers at regularly scheduled intervals, and you can see that here in the bottom panel of figures. And then they also assess quality of life by the Kansas City Cardiomyopathy Questionnaire. And as I mentioned before, these data were crucial because this came at a time, at least here in the United States, when the first therapy for cardiac ATTR amyloidosis was approved. Until 2019, we had absolutely no treatment that modified the natural history of this disease. And that drug is called tafamidis. So, and then one other key finding is that this study demonstrated the clinical severity of a specific genotype. So, patients with a hereditary form of ATTR amyloidosis due to the V122I allele. And it was really solidified that this was far more clinically severe than other genotypes. Now, why is this important? Because this mutation is virtually exclusive to individuals of Western African descent. So it becomes very hard to disentangle things like socioeconomic status from prognosis and from biology. And so this, because it captured the national caseload, really did that. And as I mentioned, this is quite valid. Again, national caseload of amyloidosis, standardized follow-up. And just like Swati highlighted, their statistical assessments were all appropriate and they adjusted for all the necessary confounding. So again, that's my last slide, and I want to thank you all again for this opportunity. Joe, back to you.